Hey everyone, on this episode, I'm really excited to have Dr. Chris Chapman on the show. We did a research review of one of his papers. He's got 4 publications. Maybe I'll list them all in the description below. But Dr. Chapman is a diplomate in the chiropractic craniocervical junction procedures. He is director of ICA's Council on Upper Cervical. He's a course instructor and designer for the upper cervical diplomate program. He's lectured to dentists and upper cervical chiropractors, and he's based out of Salt Lake City. So, real excited about this interview. We go over a lot of information about how he got into everything that he's doing and his publications and what he's doing in the future. So, I really hope you enjoy. Okay, so welcome back everyone to the Upper Cervical Chiropractic Research Show. This is episode 28B. On behalf of the Council on Upper Cervical Care, I'm Dr. Kevin Leach, and here with me is a very special guest, author of the research we're going to do today, Dr. Chris Chapman. Welcome to the show, Doc.
Thank you, Dr. Leach. Appreciate it. Good being here.
Absolutely. So today's episode, and the paper is titled Craniofacial Changes After Combined Atlas-orthogonal and Biomimetic Oral Appliance Therapy. And this is by Singh, Chapman, and Preble,
yeah.
Preble, published in the Annals of Vertebral Subluxation Research. And so just a real quick overview is this study took 11 patients who were found to have an atlas subluxation and malocclusion, measurements taken before treatment, after chiropractic treatment, and after treatment with the oral appliance, the DNA Appliance, for malocclusion by the dentist. And studies showed improvement after the atlas realignment and further improvement when combined with the DNA Appliance. So, I want to get, Doc, I want to get your background and just kind of how this study came about. But I want to know first, just for everybody watching as well, what kind of got you into to doing this and to working with, whether it be functional dentist and I know you have an actual dentist in your office. So kind of give us the background and just kind of how you led toward doing this almost subspecialty of the subspecialty of upper cervical.
Yeah, definitely. I'm kind of a data geek. I gather so much data. It's just what to do with it. It's always there living in the computer systems. But this kind of struck me early on. And this is speaking to like across the board upper cervical chiropractic clinicians. We have an experience with our patient that is largely wonderful. We have this big group in the middle of our patients that do exceptionally well with upper cervical work. Of that group, we have a number of those patients that require very few procedures, repeat procedures. They seem to, as we say, hold indefinitely. It's a wonderful thing. And then we have another little group on the other end of the spectrum that don't seem to hold very well. And they're constantly needing to be readjusted, retapped, re-imaged, and there's a bunch of instability in there. Yeah. And so this is not a singular observation of mine. I'm sure you've encountered that in your practice.
Yep.
And you get the question from the patients, why won't this hold? I feel so great when my head's on straight and that area is open up, but give me a week and I start to go down. Okay, so that's a very common observation in upper cervical practice. And I've started to observe that there were instances where the group that was very, very stable, individuals in the group that were very stable would cross over into the group that was not very stable without injury. So they didn't have a car accident or, a trampoline injury or bucked off a horse or anything like that. There was seemingly no reason why they did that. But as I started digging a little deeper, I found an innocuous, commonplace dental procedure in their historical record. They had a crown or an online, or they got Invisalign or braces or whatever. And so my first thought was, they're sitting in the dental chair with their mouth open, for an hour or so. Yeah. And I thought that was what was getting them. And yet, when I really tested that hypothesis just by query with all of my patients, the patients in that group, the patients in my general group and in the group that we're holding had all of those experiences and didn't necessarily have a crossover into the, I can't hold my adjustment any longer and I'm really unstable up here group. Okay, we'll just call that group for the sake of this discussion. Mm-hmm. And so when we really started looking at what was going on, we found that the actual anatomy and posture of the individual teeth were actually changing through orthodontia, or if an onlay was laid on a tooth or a crown or something like that, the actual anatomy, the interactive intercusping anatomy of the tooth would actually change. And we're talking microns, we're talking 15 to 30 microns. Yeah. And so it occurred to me then that something in the posture of the mandible was changing, and that was in some way changing the craniocervical junction. Mm. That's about a 5-year long series of questions and answers and questions and answers and deductions that led me up to a point where, when I was ready, you've heard that old saying, when the student is ready, the teacher shows up, right? Yeah. And so having kind of turned myself up on this area of investigation, that was when I met a particular dentist who had come in as a patient for the procedure. And, you can recognize dentists because they tend to have this position because, they're constantly in this position.
Yeah, how you doing?
So they'll have a list to one side or the other. If they're right-handed, it'll usually be a right list. Yeah. I hate to say that, but I've really, just in teaching and, interacting with, hundreds of them over the last decade or so, I've seen that pattern. And so I corrected this dentist, Atlas, and got him to stand up for the first time in so many, in 20 years of his career. Yeah. And of course, all the hand pain and stuff like that went away. But so he said, I'm actually involved with this researcher who's doing craniofacial development work. And this was where I met Dave Singh. And so he gets out his cell phone and he calls Dr. Singh up on the phone and is trying to explain to Dr. Singh, as a dentist, what I do with the Atlas. And he was totally botching it. So I'm like, give me that phone.
As they do, right? Yeah.
Well, it really is. You really come into, you encounter these understanding boundaries and limitations between the professions. They know a ton about the mouth and the face and all of this stuff. But, when you consider that every dentist that you've ever seen, all they have to do when they look in your mouth is pull aside the uvula and look back at the soft tissue on the back of the throat, and they're looking at our space, right? Yeah. They're looking at the craniocervical junction. Yeah, yeah. And so I got on the phone with Dave and I basically said, this is my short version of the story, by the way. I basically said, this is, adjusting the Atlas changes the relationships of head, neck, jaw, and the body and everything like that. And he had an epiphany on the phone and he said, so that's how the jaw and the head and the neck gets to the rest of the body. So Dr. Singh had that epiphany. And from that conversational epiphany that he had, he was going to be in Salt Lake City, my hometown, in like 2 weeks and be doing a big presentation to a group of dentists who were taking his advanced biomimetic, course. And he said, hey, Dr. Chapman, would you want to come do like a 15-minute presentation? Nice. And I said, sure. Yeah. And so I went, and I was literally behind the podium for 2 hours taking questions. And I just, it was like, okay, so this is a group that is super interested.
Yeah.
Yeah, very interested. And then I think the most significant thing that happened in that one, visit, that one encounter or seminar weekend that ignited all of the research for me was when one of the dentists, as a patient who was taking delivery in a lab setting of a DNA appliance, actually laid down in the dental chair. And of course, all the dentists are, up around his face, watching how Dr. Singh would install the appliance in his mouth,
Mm-hmm.
and I was standing at the foot of the dental chair, and when
Checking legs.
well, not literally, but with my eyes, right?
Yeah.
So, yeah, you got it. We think alike, and so like this really tall, I mean, he's like 6 foot tall, lays down, and thin, lanky, not heavy at all. And I looked at the bottom of his shoes, and I saw one leg, literally, I'm not joking, like an inch and a half pulled up, and I'm like, hey, Marty, are you sitting on a wallet or something like that? I mean, and he goes, no, I've learned not to do that, and so I don't do that. So I observed that leg length inequality. That was my first observation. And as they were installing just a flat planed occlusal acrylic chunk in the guy's mouth up top, I started to watch his legs go from here to here. And it was like the first generation iPhone, I think. I took it. So I reached into my lapel pocket, took out my iPhone, and went,
yeah.
And so I got like about nine images, and he's not adjusting his body. That's the crazy thing. He's not notably adjusting his hips in the chair, but I watched the leg length just simply change and go from about an inch and a half short to about a quarter inch long. And I was just blown away. I'm like, wait a minute.
Yeah.
So on a break, I took Dave aside, and I said, Dave, look what I just saw. And I scrolled through my phone, and you could just watch this leg drop down. And his mouth dropped open. He said, what just happened? And I said, I don't know. I was hoping you could tell me. And he said something, Dave is a great researcher. He said, do you think we could do it again? And I said, I don't know, let's try. And so we kind of spitballed a protocol. And so we agreed to take patients. We just set our protocol up. And that was that was the end of 2011.
Okay.
And so that led to our first paper, which was a prequel, if you will, to the paper we're going to talk about today.
Okay.
Which was the craniocervical junction effect on leg length inequality, which was also published in the same journal as this paper. So that's how this started. This started by observing actual full body leg length changes by occlusal changes. So that's been my decade long. And really, I've been unrelenting, digging up research and developing clinical protocols and collaborative protocols, et cetera, around that phenomenon.
Nice. Cool. Well, okay. So lead us into, that was what, 2014 was this paper.
Yes.
The leg length rate, looking right here, was the 2013. So it was just the year prior.
The year prior, right.
So walk us through the current one here, in regards to maybe just the evolution of going from the leg length to this specifically. How did that come about?
So we measured leg length against a grid, and we did the same sort of thing, the same sort of protocol. We measured pre leg length before the craniocervical junction correction was made.
Right.
Then we measured we took images. So we didn't change everything. We didn't like redo the protocol. We took the data because we had a lot of data from the initial. We did craniocervical junction X-rays and cone beam CT scans. So we had all that data anyway. We just wanted to introduce the subject through the leg length inequality portal because of the recent study by Woodfield and Nuka and that moderate reliability relationship. So we thought we'll start there and create the conversation in the literature, and then we moved into actually looking at the actual images. So that's what this table is. So when we there's a lot of joints, as you know, by the time we get from the head to the feet.
Of course.
But we concerned ourselves primarily with those areas that are sort of germane to the orthogonal based upper cervical chiropractors. And so we looked at the relationship around the various axes of the atlas under the foramen and magnum, skull base, C2 under C1. We looked at the head tilt. We looked at how the atlas was relative to the horizon. So we looked at plane line, and we looked at what we might call the angular rotation, or the relationship of the base of the skull from the top of the cervical spine deviated into, the z-axis, if you will, the right or left frontal plane. And so and we did measure all of those angles individually, if you look at the tables and you look at the paper.
Yep.
But in order to grapple with that much, those many joints, I decided to summate them, add them all up, and give them a numerical value. Because when we're talking about something like compensation and adaptation into the body, you have to have something tangible that you can do statistics off of, and numbers and units of measurement are that's what we relied on. So we summed all the amount of angular rotations and deviations from normal upright alignment, and we measured them to start with. That was T0.
Got it.
And then we introduced a corrective vector, which is what we do, Dr. Leach. Obviously, we have different ways to go about that. And as a diplomate in the craniocervical junction procedures, there are many wonderful, good ways to go about that. And I'm supportive of all of those ways. So I'm Switzerland in that area.
Yeah. And
so I happen to use a sweat instrument to do the work. And so essentially, we saw that there was a statistically significant increase or decrease or an improvement in the alignment. So we reduced those decompensation stressors on the body by a certain percentage.
Yeah.
And that's our T1 measurements. And then T2 was, in addition to that, without any other upper cervical interventions, we installed a biomimetic appliance that was flat planed. It was not indexed. It just simply acted to disclude, take the anatomy of the teeth apart, and place them into a balanced, very generic bite, if you will.
Okay.
We've learned a lot. At the last 7 or 8 years, we've learned a lot. We can talk about that at the end.
Absolutely.
But for the sake of this paper and this sort of point in time, we then experienced the additional improvements in those compensation numbers. Does that make sense?
Yeah, absolutely. I was hoping you would explain the craniofacial parameters that are discussed in the paper. What does that mean?
So for the term craniofacial, and as I look back on this, we look back at some of our previous work and we go, I could have said, this could have been said a little bit better. So the craniofacial implies the head and the jaw. So the element that we were making changes to in this particular study reference bite. So,
Got it. Okay.
So the teeth, when you think about it, and I have a manipulable here.
Nice.
So when you think about it, the jaw, the mandible here, the lower jaw is connected to the skull,
right,
and also the front of the face.
Right.
So the jaw is the bridge that bridges the cranium to the front of the face as a mobile joint.
Right.
We have a lot of sutures that do it, but this is its primary effect then is to kind of bridge the head and the neck and support the front of the face. So when we make changes to the posture, and I'm going to use the word that we all understand and love, when we change the posture relationship of the teeth, essentially we're going to affect the head on the neck and the other structures. And I'll show you practically how that works, but if you're curious.
Yeah,
so we were talking about craniofacial as the teeth. We should have said craniofacial cervical. We should have included the cervical in our description because because most of our changes that we actually measured were at the craniocervical.
Right. And then the additional for the craniofacial.
We changed these. We changed posture relationships craniofacially, but our effect was craniospinally.
Right. Yeah, totally.
Yeah, that would be a clarification in the next iteration of papers.
Got it. Now, is the DNA Appliance still kind of the oral application of choice, or are there others? And what are people using nowadays?
No, that's a great question. So the DNA Appliance is a wonderful appliance, but it's it's a long slodge of growth, and having I'd never say anything negative about the idea of biomimetically growing or stimulating bone growth through intraoral appliance systems. That's a cool idea. It's in the realm of the extraction osteogenesis, and I just kind of lump all those into the appliance guided osteogenesis platform.
Got it.
But what works more immediately is to actually develop something, and we've developed this. It's called an Equibite, and what it is it's a stabilization appliance. So and it's indexed, so it's got you can kind of see this. It's got little anatomy features on it. It's thin. It's just a little bit bigger than an Invisalign aligner tray. So it's super thin. It's custom designed to every patient. And what it does, when you change the head and the neck alignment of the patient, that changes the trajectory of the mandible. Always. How do we know that? Because I measure it pre-post. I have some technology called the T-scan, which is an instrument you may have been familiar with or are familiar with, which actually measures the first contacts, and bite force distribution in the bite. So invariably, upper cervical doctors, when we do our procedure and we change the posture of the head and the neck and the jaw, we're going to change the trajectory of the jaw. Just like if you had an old swing set and the branch was bent and you straightened it, you would change the arc on the swing set. It's very simple. But what happens then is, if you do not address in this group of patients that have strong occlusal interferences, if you do not address those in some way with a little temporary prosthetic that retrains the system, as soon as they go through a number of contacts of their teeth in their habitual bite posture through swallowing or something like that, or clenching, heaven forbid, they lose their alignment here. And the alignment of the craniocervical junction that they so treasure, and that we focus on providing clinically, actually relapses, and it relapses down into the misalignment or the subluxation. And so rather than going through a 2-year growth process and changing all this stuff, we can give them a little stabilization appliance that they can wear for a short period of time, and then we wean them off of this. So this is it goes in the mouth, but I want to be really clear. This is not a dental appliance. This is a chiropractic orthotic. Okay?
Oh, wow. Yeah.
It's built primarily to stabilize the head and the neck and jaw relationships, which then maintain all of the postural decompensation changes that we like to see in our patients that are healing and progressing.
Fantastic. Now that's only your appliance, like you've developed that in-house, so that's not like there's not other chiropractors that are using that?
No, there aren't, but we want that to change.
Right.
We want this to get out there, because this is largely solving the problem of relapse.
Yeah.
And the reason I started thinking about this, and we didn't capture this in the paper, but those patients who were actually in the stabilization appliances, or not the stabilization appliances, but in the growth appliances. And I'll be honest with you, we did about 500 of those. So we don't have a small group. We did a lot of appliances in our practice over the years. And we found that those patients markedly needed fewer adjustments. So my new stats are really, if I take last year, I saw about 1,000 patients. We did stabilization patients for all of them, and my average number of adjustments on my patient is floating somewhere between 1.5 to 1.7.
Yeah,
that's the total number of adjustments,
which is hard to believe, I must say.
It is hard to believe. I know. I know it is.
I mean,
you wonder, am I squinting? Am I just not,
right.
this is, I've had a couple of associates come through here who have observed the same sort of thing.
Yeah.
And you can literally observe, you can stick this appliance in if they're out of alignment. and you'll watch the leg level and the cervical spine clear. And if you happen to take images, I don't do this anymore. I've investigated this, you get a reduction or change, just like we showed in the paper. That is consistent. So it's kind of our end goal. I think, as a doctor, we want to adjust our patients, but that's great. But we also want them to not need that adjustment again and again.
Of course. That's the whole goal. I mean, that's what we tell our patients all the time. Like our end goal is to not adjust it.
Unfortunately, we're kind of set up. We have to see our way around this problem, because it triggers a money event every time we have to adjust them. And all of our patients agree, and you get this a lot, Dr. Leach. People will say, that was the best thing I've ever had happen. I paid for numerous physical therapy and orthodontic appliances and surgeries, and nothing's worked. What you did was life-changing. So put a price tag on that.
You can't.
You really can. It's more than all of the other stuff. It floats somewhere in there. That's a tremendous value. So I'm, and I don't want to go off into this practice management stuff. I really don't. But I found that the value of the adjustment is actually more suitably established in reality because of what it does. And if you can help it stay and remain in its position and its posture, then you've got something really, you've got that cure that,
Absolutely. I mean, that's the end goal. I mean, anybody that's doing upper cervical work and with the x-rays and everything, it's like, we're trying to get our patients to hold. Like that's, when we get a difficult case, we're looking at the x-rays and we're, maybe I should change the vector and blah, blah, it's like, but as many variables as we can find that are affecting the ability of our patients to hold, I mean, why not address those? And so that's
agreed. Agreed. And this of course is my world. It represents a small part of, the overall objectives for all of the upper cervical specialists. But it's why I only have one table. I don't use it that much. I use it. It's like the focus of my practice, but the rest is just, let's help you to stay. And let's keep you in position. And then what's really extraordinary after this, as we wean them off the appliance, we find that there are interferences, working and non-working interferences in their occlusion. And for that, we need to team up with a discerning dentist who understands the anatomy and posture of the bite and its powerful influence into the brainstem posture mechanisms. And so that can be done. So that's all of my patients, probably 75% of them finish by having their occlusion adjusted, and almost 95% of those, there's a crown or an onlay or something that was laid on, just not refined to the need of that patient. So you need special instrumentation to do that. And so
now is Dr. Singh the author? Is he the one that's in your office now?
No, Dr. Singh. No, so what we've developed a whole new model. I started with dentists in my office, and we did a lot of the mercury revision, all that stuff. We kind of deep dived into holistic and healthy dentistry, which is super important. That could be a whole topic on its own. But what we've done is we've developed a collaborative platform, and this is where it's cool, Dr. Leach, and really can sort of spread out to upper cervical chiropractors. We've developed a platform and a protocol, if you will, where we can do our aligning procedures and get the head and the neck and the body primed and rehabbed and stable, and then we can offload them and collaborate with discerning dentists in our area. That's a whole effort that I've moved this from, our little specialty clinic that you have to get on an airplane to come and see, to taking the understanding and knowledge and putting it out there in the public domain, so that upper cervical specialists that are so inclined and dentists who are so inclined to work with them can work together, and we have a collaborative platform and everything
Awesome.
for them
Do
to
you
use.
now, is that
maybe we can
up and
talk
running?
about that at some other time.
Yeah, is that up and running? Is that, do you
It is up and,
okay, so I mean that's something I could, you know, put in the, you know, put a link in the description or something if people, you know, people are interested in that.
We do this through an entity called the Dentist's Friend.
Okay.
And so all upper cervical doctors that understand this, we would consider ourselves as the dentist's friend.
Dentist's friend, yeah.
Okay. Yeah.
Great. Okay, do you want to lead into maybe more of your recent stuff that you're doing? So we talked about 2013, 2014 studies, and then so what have you done since then? What's in the what's on the burner? And
okay, very good. So lying within all these images that we've done, the CBCT images. So you're familiar with cone beam CT, right?
Yeah.
So with cone beam CT, we can actually, if you invest in the module or get some aftermarket software, you can take the data and computer render an airway, a 3D airway. And you know, if you look at a 3D airway, here's a printout. Here's a, you know, a 3D printer version of an average airway here.
Right.
Here is,
so that represents the air, not an actual anatomical structure. That's the space.
This is the space. Good,
right.
Good on you. That's exactly right. So when you take a CT scan, the air fills in there. This is the airway space. And so when you look at this, this is the powerful changes. And this is what's so exciting I think for every upper cervical chiropractor. So when you look at the upper cervical spine, right, the pharynx, we'll call this by its proper name, it's the pharynx, or the upper airway, sits right in front of that.
Yeah.
So the front of the cervical spine is the back of the airway. Right. And so the front of the airway, where my finger is here, is the back of the tongue. Right. So the back of the cervical spine, atlas axis primarily, which is where most of these restrictions take place. So if I've got an axis vertebra or an atlas vertebra that is twisted into this space, I'm literally going to encroach functional breathing space by a lateral mass or body, a C2 body. Seriously, I see it all the time. And so the muscles, if we look at the side, those muscles are all controlled neurologically through the nucleus tractus solitarius and these pharyngeal muscles, which happens to get its blood flow from the vertebral arteries, right? Which pass through the craniocervical junction. So what I found when we do, so this is the same patient. This is a 3D printout of this patient's airway.
Nice.
This is before, this is after. Okay.
Not bad.
This is a very famous singer. So this is what happens when we adjust C1 appropriately and take the pressure, take the encroachment off the back of this space and open up the neurology that feeds and also takes nutrients out, you know, takes the debris and the waste and metabolism out of there through the venous plexus in that area. So when we do our craniocervical junction work, we immediately, just like the blood pressure study that Dickholz and Pacris did, we immediately make physiological changes that are measurable on CT. And the improvement in minimal cross-section area, which is our key, that's the constriction point. That's the point in an hourglass that keeps time. That's the determiner of how much sand pushes through. Well, the minimal cross-section area here is what determines how much air comes through, right? And so what we're finding is that with a measurably reduced craniocervical junction, we get anywhere from 13 to 300% improvement immediately in the airway space, Dr. Leach. And that is why when you do a good procedure, you know, and the patient sits up and you check them, they're like, breathe better. Is it in my imagination or can I actually breathe better? It's like yeah, baby, and here's why. You gotta, we just improve that. And so the next research really that we've got all the data on right now, we're just refining it, is to show that the tremendous changes that we can make in not only wake breathing airway, but sleep breathing airways.
Nice.
And so we really make a difference in that critical area of, say, obstructive sleep apnea, which once you enter into obstructive sleep apnea, all of the diseases and conditions statistically go up.
Yeah.
Heart disease almost doubles, diabetes 87%, all kinds of cancer, every cancer 63% increase.
Mm-hmm.
So this is why insurance companies have actuary tables, and they measure this stuff, which is why they're so willing to give you a CPAP machine, right? Because a lifetime of CPAP hoses and filters, et cetera, barring any discussion about the nonsense that's come out on that lately, is better than one. It costs less than one stent in your heart. Right. So you get what I'm saying? So So we as upper cervical doctors who are image guided and image based can actually measure changes in that area. And I think that is a message, honestly, that should be heralded from the rooftops,
Absolutely.
So
absolutely. How was that study being structured in regards to the awake and the sleep? Is it like sleep studies or
sleep studies?
Okay.
Yeah, you need a sleep study. So you need a sleep study. You need to do a pre-initial sleep study, and you need to do a wake study. If you're going to talk about sleep, you have to measure it. You have to measure it objectively. And, people can say, oh man, I feel so good. I'm the best sleep. I don't snore anymore. Well, that's really important. That's qualitatively very valuable.
Right.
But in order to really actually, make a change, get anyone's attention on that, you have to have
measurements.
Sleep studies.
Yeah, for sure.
So we have a pretty cool sleep study, take-home sleep study that actually has masseter sensors on it, so we can measure certain parameters of sleep.
So you're going to do a pre-measurement for sleep, post-measurement for sleep, and are you doing in between there? Is that the Atlas adjustment and the Oral Appliance both? And then you do okay.
Yeah.
What timeline is that as far as before and after?
4 months.
4 months. Okay.
4 months.
Nice.
Yeah.
So that's the next one in the
there's just a lot of data.
Yeah, totally.
I need data slaves.
I talk about this with Dr. Evans all the time. It's like we're reviewing all this research, and there's a lot of good stuff out there, but the people that are doing these research papers and studies are people like you that are running a practice and supporting a family. It's like we don't have the NIH multi-million-dollar funded studies.
Don't get me started. We're not Pfizer, right?
Yeah. Well, yeah. All right. So is there anything else as far as just about these studies or what you're doing that you want to share just with either upper cervical doctors or just even people that are patients or people interested in this work, that they might even be going to an upper cervical doc and they'd be like, yeah, that sounds kind of like me. I don't have, I don't hold as well as I'd like to. I'm doing a lot better, but I wonder if, there's something else that I could do here.
Yeah, that's good. That's a good question. Not every doctor has a CBCT machine to use to do this. And one of the precursors that I and a colleague of mine, Dr. Kevin Siegel, did is we crunched a ton of data from the 3D CT scans, looking at the minimal cross-section area. I'll send you that.
Great, yeah.
That research there, but we identified and statistically correlated the minimal cross-section area in a 3D study to a 2D study. So a 2D sagittal or lateral X-ray, if you find the minimal cross-section area there, and I can show you how to do that. We wanted to establish that because we knew that a lot of doctors don't have the sophisticated equipment that we have, but most of them most all of the upper cervical doctors that are working in the, I think, in the more discerning, whether you're Blair or atlas orthogonal or NUCA or, you know, whatever, right? They're using images to guide them in the process, which means that they have a pre-procedural study, an image that's objective. And so, and if you control certain features of that and look at, maintain the hard palate line, et cetera, you can actually, if you do post scans, you will see there are some measurable changes in that, not 3D cross-sectional cross-section, but in the A to P dimension. That's where we found a super high statistical correlation. And so that means that somebody with an X-ray system can actually do a post sagittal and determine whether or not they've made some craniofacial, upper airway or pharyngeal changes.
Cool. Yeah, I mean, I remember seeing that all the time, even, and I know, you know, Dr. Rebecca Taylor.
Oh,
she's,
yeah.
You know, she's up the street with me. We've planned, you know, before COVID happened, we were like, yeah, we should go take a trip out to see Dr. Chapman. I was like, yeah, let's do it.
Come on out. Get in the hip van and come on.
Yeah. But, you know, we've worked with patients together in the past, and, you know, because it's fresh on their mind, they'll see the lateral that I go through with them and they're like, oh, look, there's my airway. And I'm like, yeah, it's right there. Like, it's right there.
Yep. And you'll see changes in tongue posture, and those infrahyoidal muscles will pull down. And it's pretty extraordinary what the changes that we're actually causing that are actually measurable. I mean, we get to hear the wonderful success stories of our patients, just generally telling us that they're feeling better. But man, when you're dropping blood pressure and opening airways, I mean, come on, that's like physiology changes. And what's cool for us is we can actually measure it and show the patient, hey, here's what we changed. Here's why you're breathing better. Here's why you're sleeping better. Does that make sense?
Absolutely. I wanted to ask you about just kind of the TMJ just in general, and what influence that has in regards to whether it's, you know, affects the appliance, or if the appliance affects the TMJ. And also, are there different, like, do you give like stretches or exercises or anything to kind of, you know, to target the TMJ?
Yeah, that's a good question. So when we look at the, so again, I'm going to pull up my little base of the skull. So orientation, this is the base, right? And so TMJ is temporomandibular joint. And so when we look at these joints and we look at them from this standpoint, we see that the temporomandibular joint is here and here. And then if we take our little friend, the atlas, we see that the atlas lives right here.
Yeah, very close.
So the muscles that sling and operate the temporomandibular joint, the 68 pairs of those muscles, actually cross over, bridge and cross over and attach and pull and tug on and around the craniocervical junction. So if we have postural changes to the bite, then the actual muscles that attach to the cranium, we can see those, the big ones on the outside of the cranium here, or the deeper muscles, the pterygoid muscles here and here that attach to the jaw, to the sphenoid, and et cetera, the cranial systems. When those muscles have to start adapting and compensating for bite occlusal changes, remember, 15 microns, something there, then the jaw joints the jaw has to posture itself and adapt into that new bite. It does. It takes those muscular, we could say neuromuscular forces, and twists and rotates the C1. Does that make sense?
Yeah, totally. It makes me think of like the chicken or the egg. Like, what's the, you know, what's the original problem? Because there's such a cascade of events that happen or could potentially happen.
So it was definitely the egg that came first, but it was laid by a bird that wasn't a chicken.
Okay.
That's according to Neil deGrasse Tyson. Great. That's a great quote. So I didn't originate it. but I use it frequently. So, and the better question is, what's the best order of operations for intervening?
To correction.
My belief and experience is the best way is to, let's go right to the central neurology, right where my finger is there. That's your brainstem, and the vital area that flows around the craniocervical junction and through it. Let's get that right, because that changes the context of everything. And then let's think about adjusting the teeth later. The jaw is this wonderful little compensatory adaptive joint that can take so much beating, but finally it hits the wall and says, ouch. And then people have, TMJ pain, and they light up their trigeminal system, et cetera, et cetera. So the key is to get back to domino 1, not domino 2 or 3. And I think oftentimes the jaw joint is domino 3. And so if you want to address domino 3 and rehabilitate it, get this right, stabilize occlusion by giving it a different landing point. And then to answer your question directly, the muscles and nerves, fascia, those engram transducer feedback loops are all they're all going through physical therapy and stretching every time you swallow your saliva. Your teeth come together on the prosthetic, and they're retrained, and your brainstem goes, oh, that's where I land. I like it. That's where I like it.
Love it. Yeah.
Makes sense? So it's really a procedure based, and all the patients have to do is do what they normally do in normal, healthy physiology.
Right. Yeah. I love it. I love it. Cool.
Yeah.
Great.
Cool stuff.
Yeah. All right. Well, we spent a lot of time here. Hopefully we didn't bore people too bad. I loved it.
I hope not.
Yeah. Do you have anything else that you want to share? Do you have any, links or anything, sites that you want to point people to, or anything you want to end with?
Yeah, that would be great. So my clinic is theliftclinic.com, and my URL is theliftclinic.com. You can also get to our little section called thedentistfriend.com, but for now I would stick with theliftclinic.com, and Dentist Friend's going to be switched on here in about a week and a half.
Cool.
Or maybe 6, depending, how web designers go. So, but this gives everything we've talked about today. I have blogs and a description of a process. And of course, I'm in Salt Lake City. I'm, as much as time will permit me, I'm very, very willing to reach out, talk to my colleagues, whether you're a dentist or whether you're an upper cervical specialist, and help meld and merge that conversation coherently. So that's my goal. That's what my interest is for my days. So
sounds good. Awesome.
Theliftclinic.com.
There you go. Dr. Chapman, I can't thank you enough. This was an honor, and I appreciate you and everything that you're doing with the council and the diplomate and everything. And keep up the great work. You're appreciated probably more than you're thanked for. So I'll thank you on behalf of everyone who doesn't get to thank you. So thank you so much.
Thank you, Doctor. That means a lot.
All right, Doc.
Thanks.
Thanks. Yep. Okay, that's it for this episode. So what did you learn that fascinated you or surprised you about the research today? Join or start the conversation in the comments below. Hey, thanks so much for watching. To watch more of our research shows, click or tap the screen right there. To subscribe to the channel, click or tap the screen right there. Until next time, I'm Dr. Kevin Leach with the Upper Cervical Chiropractic Research Show, bringing awareness to conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic. Until next time, take care and take care of your spine. It's the only one you'll ever have.